And we organized so that the next talk by Jason Doctor will be about some of our previous experience with the scanner without P. Um, and then it's also based on some safety net clinics in the Los Angeles area, so as well as other centers. So Jason from USC.
Okay, thanks, Lucilla. I'm going to talk today about work that's funded from an RC4 that was ARA funded. And we got this funding around 2010. And Daniela called me. She was part of the project. And she called me about 2 weeks later and said, hey, I'm really excited. Scanner got funded. And I didn't know what Scanner was. But I said, gee, that's great. Little did I know it would become so useful to us because we use the Scanner technology and the Scanner principles in our research. And so this is really the first use of the OMOP data harmonization for doing randomized trial in Scanner, use of the sample management system, et cetera. So now I know what Scanner is. All right, so we were responding to an RFA on use of behavioral economics to increase the uptake of comparative effectiveness in medicine. And many of you might not know what that is, so I'm going to talk a little bit about it. Originally, the traditional view of clinician behavior is that clinicians are reflective, logical, deliberate, that they respond to alerts, reminders, and education. This is how I was raised in informatics, in the informatics textbooks. And then economists also think that monetary incentives work and that they kind of operate independently of what a clinician thinks about themselves, whether they think they're a good doctor or how they practice medicine. So the behavioral view is a little different. The behavioral view is that the clinician faces time constraints and they're engaged in really demanding work, and because of this, their thinking is fast and it's affected by how information is presented to them. From an economist standpoint, if you're a behavioral economist, then you don't think of a monetary reward as a simple additive motivator. In other words, you don't just give people money and then they perform more comparatively effective practice. And then the other thing is that social cues can affect your decision making. So traditional decision support, it's very disruptive. You're practicing medicine, an alert pops up, and there's a lot of information you have to read. Then you have to decide whether you're going to click out of the alert, whether you're going to respond to the alert. And the results of decision support have been mixed. Somehow when I transferred to the scanner slide set, it changed all the parameters. But okay, so this graph is a meta-analysis by Bright in 2012 on decision support and its effect. And as I said, the results are mixed. Oftentimes, there's no benefit to decision support at all. If you look at economic approaches to changing behavior, a Cochrane review in 2011 said there was insufficient evidence to support or not support that financial incentives actually work. There was a paper in 2009, a big study, Pay for Performance, done in the UK, where they gave very large incentives. 25% of your pay was connected to providing quality care. And what they found was that it did have an effect, but that anything that you were not incentivized on got worse. So you started to focus only on what you were being incentivized for, and you weren't doing things like calling the patient to see how they're doing after they were released from the hospital, for example. And then a large trial in JAMA in 2013 was unable to find an effect for sort of moderate pay for performance, the type we'd see here in the US, and this was a US study. So we're looking for alternative ways to change behavior. And what we know is that people do respond to large incentives, but it's not always practical to give them large incentives, and that incentives can have complicated effects. So if you incent on one thing, maybe another measure will get worse. Also, because physicians are constrained in their work environment, their work is very fast-paced, they don't always see the outcomes after they make their decisions, so they don't always know what happens. And their decisions might be influenced by outside factors. We thought we might be able to use some of these facts to devise a different approach to decision support. So when can we use this behavioral economics view? And I'd like to say it's not a panacea, because you can use behavioral economics to convince someone to buy a blue house over a yellow house by nudging them in a certain direction, but you can't convince them to live in a cave over buying a yellow house. So the types of things that behavioral economics works best for are things where the physician has no strong preferences. So imaging for low back pain. A person comes in with low back pain, there's probably nothing wrong, just garden variety low back pain, but they're going to do an image. If they didn't do an image, it wouldn't be a big deal. It's not recommended to do an image for garden variety low back pain. Antibiotic prescribing for the common cold is another example. And washing your hands before you enter a patient's room would be another one. So our group and other groups have been doing research in this area. And the way that we operate is using a data network, using the scanner network, which is a network of clinics. We also incorporated other clinics that are now this predated the PCORnet idea, and so we have clinics that are now part of Skills and Capricorn, but really the data that are harmonized are mostly through the P-Scanner clinic, or the scanner network that is part of the P-Scanner grant. So what we do is we employ randomization, because even if you have big data, you still need to get to knowledge. You need to randomize if you want to be very sure about that knowledge, and so we conduct randomized trials in this data network. These are cluster randomized trials where we randomize clinics. And then we deliver a nudge either at the point of care or in some way that affects we hope to affect clinician behavior. So we took on this problem of acute respiratory infections and inappropriate prescriptions of antibiotics. These 10% of all visits to ambulatory visits are for acute respiratory infections, and about 44% of them you get antibiotics, and about half of those are inappropriate. So that's a lot of inappropriate prescriptions. Of course, it increases costs, and it increases the potential for antibiotic resistance and adverse drug events. Prior interventions have been somewhat successful, but not very successful. And I'm not going to talk about all the different studies we've done in the scanner network. I'm really going to focus on two techniques that we've used that have been most successful. We drew a lot. One of our collaborators, Noah Goldstein from UCLA Business School, is a social psychologist, and he worked with Robert Cialdini, who came up with the principles of influence. Cialdini decided that he wanted to understand how to influence people's behavior, so he went out into the field and he talked to people who have to influence people's behavior to make their paychecks. So he went to salespeople, car salesmen, all the people that you encounter that have to try to influence your behavior. And he came up with these principles: reciprocity, social norms, commitment, liking, authority, and scarcity. And I'm only going to talk about social norms and commitment today. Social norms is simply this idea that we compare ourselves to others. We look to see how others are doing, and then if we're not doing as well as other people, we correct our behavior. And commitment and consistency is this idea that if you make a prior public commitment, that you're more likely to follow through with that action in the future because you want to appear consistent with your prior public statement. So you've probably encountered this with salespeople before. But anyone bought a used car or a new car and you had a weird encounter with a salesperson where they said something like, "If I could get you into that car today at the price you wanted, would you drive it home?" And you felt a little strange. Well, that was it. They're trying to get a public commitment from you. So this idea of social norms has been already tried outside of health in energy consumption and reduction of use of energy. And it was first done by Cialdini in a small study in the Tucson area. Later, Hunt Alcott did a very large study on 500,000 homes in the U.S. And simply what they did was they changed people's electric bill. I'll talk about the Hunt Alcott study because that's a much larger study. But instead of just saying how much power you use, they showed how much you used relative to an efficient neighbor that lived nearby you that had the same size house and the same energy consumption. If you had a pool, then this neighbor had to have a pool, etc. And then they showed your energy consumption. And then and the bottom bar shows you all neighbors. And so if you were doing worse than your neighbor, then your bar would be higher. And you got this kind of sad face. We have a happy face here because you're actually doing better than your neighbor. In the original study, they found that the sad face worked. In other words, if you were doing worse than your neighbor and they gave you the sad face and they showed you how much more energy you were consuming, then your energy consumption went down the next time. But if you were doing better than your neighbor and they didn't give you this happy face, which is kind of this injunctive norm saying you're doing a great job, you used more energy. So they said once they put the happy face in, like a thumbs up from an authority figure saying you're doing great, then people didn't use more energy. And this reduced people's energy bills, just showing this information to them reduced their energy bills by 6%, and that amounted to 2% of all their energy consumption, of a household energy consumption. If you look at the entire U.S. carbon footprint, just by putting in this bar graph, reduced the carbon footprint by 1%. So there's just a simple little technique to change people's behavior, and it had quite a big impact, very low cost. So we wanted to try something like that as well. So we did a social norms comparison. We called it peer comparison. And we did it in 47 clinics around the country that were most were part of the scanner network. And we reduced antibiotic prescribing, inappropriate prescribing, from 24% to 13%. And we identified qualifying visits using data across the network. And we gave people monthly feedback where we showed them how they were doing compared to their top performing peers who were providers who were prescribing in the top 10%, meaning they had the lowest level of inappropriate prescribing. We would say you're either a top performer or you're not a top performer every month. Then another study that we did on the scanner network was this public commitment study, and this was headed up by Daniela Meeker in the back. And in this study, we used only some local clinics in Los Angeles. We randomized we actually randomized providers in 5 different clinics and looked at over roughly 1,000 patient visits. And we got this idea that how could we get physicians to change their behavior through a public commitment? It would have to be visible to their patients. So we had clinicians sign a letter to their patients saying that they were committed to only prescribing antibiotics when they're absolutely necessary. And then we blew up that letter into the size of a poster that you would see in an exam room, and we put their picture on it. And so you have the signed letter in the exam room while they're seeing the patient, and we got this really almost a 20% reduction in inappropriate prescribing for the clinicians that were randomized to the poster condition. The other condition was no treatment control. And you may ask, well, maybe the poster had some educational effect. It's possible, but there have been studies where they've randomized clinicians to have posters that remind them not to prescribe, but where there's no commitment and they don't show such an effect. So this was a nice finding. If the effect was held up, it would save $70 million in inappropriate prescriptions and avert 2.6 million inappropriate prescriptions. So just in summary, I think the use of clinical data research networks like the scanner network is very important for changing clinician behavior. You can do a lot more interesting work, nuanced work in human behavior and psychology, behavioral economics to improve quality. Early results from our work suggest that non-monetary incentives have a substantial effect and are important. And we hope that we can do additional studies in the future that capitalize on some of these social intervention strategies. So just, I want to thank some of the people involved in this study, and also Lucilla for P-Scanner. And again, this work was funded both by NIA and now through PCORI as part of the P-Scanner network. So thank you.
All right, thank you. So any questions?
Thank you for that really interesting presentation. I was wondering if you had to get informed consent from all of the providers who were randomly assigned to these posters.
We did. We had to get informed consent. We also paid the providers at a lot of the clinics. It really depended on the clinic policy. So some of our lower income clinics wanted the money to improve their clinic, and so we handled it that way, and the people volunteered. We required a certain level of participation to get that reward, and then other clinics we paid clinicians. So as part of the stimulus money, we paid the clinicians. Yeah.
That was a great presentation. So a two-part question. One is appropriate prescribing is always a challenge. So how did you benchmark that? And the second one is we had funded a clinical decision support tool project which automated integrating prediction rules into EHRs. So this was for strep throat and pneumonia, and that did improve appropriate prescriptions. So how do you balance automating these as opposed to more psychological behavioral reminders?
Right. Well, we went through this torturous process of developing a quality measure for inappropriate prescribing. And we went through all the different. There wasn't actually one that worked the way we needed it, so we had to develop one with our physician team. I think the work that Daniela presented earlier on HQMF is going to be really useful in the future for this type of research because with all the different measures that you have in through HQMF and other sources, potentially you can automate development and use of those to identify qualifying visits. So, in this study or the data that I presented, we were able to look at the data and calculate people's performance and send them emails back. And in the commitment study, we just looked at the data at the end of the study. But there were some interventions that we carried out that involved point-of-care decision support, and that required that we trigger decision support at the visit, and we had to come up with a set of qualifying diagnoses and then exclusions, and that's what we did.
Other questions? Howard.
For inappropriate antibiotics, just as an example, if there are certain data elements that are not picked up, you don't all those 20%. I mean, you don't know that they weren't actually appropriate, but that you weren't picking up another indication. I mean, how
So
how
what
do
do
you know?
I'm not sure I understand. Are you saying if they had a diagnosis that was considered appropriate that was written down, or?
Right. So that if you're only basing it on I mean, unless you had someone actually reading through the chart to know that it was inappropriate, I imagine you were picking up different data elements in there.
Right.
that-
So yeah. So the way that we did that is that we had diagnoses that were not appropriate. We had ones that were sometimes appropriate, and ones that were always appropriate, like pneumonia.
Right.
And then we looked at only the not appropriate, but then we also looked at drift. So I didn't present that here, but we looked to see if clinicians were changing their diagnosis.
Oh, I see. Okay.
So we didn't do. We did do some chart review, but it was around 30-day returns to make sure that our intervention wasn't harming people. That was for a data safety and monitoring board. But we didn't do individual chart reviews of each case. There were 17,000 cases, but we just looked at to see if there was any shifting in diagnoses, and we didn't find any.
Okay. I see. That's interesting.
Well, thank you, Jason.